Good morning, all. So, in continuation to the previous video of pathophysiology of HIV, I would like to continue this topic by telling all the clinical features and different infections and neoplasms of the HIV. So, as I've told, yeah, the natural history, clinical features, and infections and neoplasms would be the main topic of discussion today. Yes. So as we all know, the major abnormalities in the immune system in AIDS would be the T cell abnormalities, contributing to lymphopenia, CD4 plus T cell depletion, CD8 T cells lymphocytosis, reversal of the CD4 CD8 T cell ratio, and decreased production of the cytokines by the CD4 plus T cells, and decreased antibody dependent cellular cytotoxicity by, that is ADCC, by the CD8 plus T cells. And your B cell abnormalities, there is no direct viral damage to the B cells. So there is decreased immunoglobulin production, polyclonal activation, hypergammaglobulinemia, and circulating immune complexes. NK cells as well as monocyte macrophages also they don't have any direct damage or by the virus, and they are decreased in number and decreased cytotoxicity, decreased chemotaxis as well. So as a whole, the HIV disease spectrum would be once the person gets affected with the HIV exposure, an acute infection is triggered, or sometimes the person can be an asymptomatic carrier or a symptomatic carrier. So these symptomatic carriers are the patients who develop the signs and symptoms of PG, that is progressive generalized lymphadenopathy, then ARC, AIDS-related complex, as well as increased infectious opportunistic infections. And these persons are also triggered to the formation of Kaposi sarcoma or else other cancers or other neoplasms and infections, and therefore they succumb to death. So natural history would therefore progress from an early acute syndrome to a prolonged asymptomatic state to advanced state. So generally in an immunocompetent host, the biological course passes through the three phases. First phase would be acute HIV syndrome. Entry of the HIV into the body is heralded by the following sequence of events. High levels of plasma viremia due to the replication of the virus. Virus-specific immune response by the formation of anti-HIV antibodies, which is called as seroconversion after 3 to 6 weeks of initial exposure to HIV. Then initially there will be a marked reduction in the CD4 T cells, that is your helper T cells, followed by return to normal levels and rise in CD8 plus T cells, which are called as cytotoxic T cells, and appearance of self-limited non-specific acute viral illness, that is flu-like or infectious mononucleosis-like, in 50 to 70% of the adults within 3 to 6 weeks after initial infection of the HIV. Manifestations include sore throat, fever, myalgia, skin rash, and sometimes even aseptic meningitis. So these symptoms resolve in a period of 2 to 3 weeks spontaneously. Then there would be another phase called as middle chronic phase. This initial phase is followed by a phase of competition between HIV as well as host immune response. So in this phase, what will happen is the viremia. Viremia is nothing but virus in the circulation. So due to viral replication in the lymphoid tissue continues and it further progresses to a chronic stage depending upon the host immune response. You may continue as long as 10 years. So although the CD4 T cells will continue to proliferate as a defense mechanism, but the net result will be there is a complete fall in the CD4 T cell count, and CD8 plus T cell count will be remaining high, and the reversal of the ratio occurs, and there is a stage of latency, and the patient may remain asymptomatic for years together, who has only developed a mild constitutional symptoms and persistent generalized lymphadenopathy. That's called as PGL. Final crisis phase would be as it is a crisis. Yes, this phase is characterized by profound immunosuppression and onset of full-blown AIDS and has the following features. What are the following features? That is marked increase in viremia. The viral particles will be completely elevated in the peripheral circulation or in other lymphoid tissues, and the time period between the HIV infection through the chronic phase into the full-blown AIDS would be lasting up from 7 to 10 years and later succumbing to death. And CD4 plus T cells are markedly reduced, that is below 200 per microliter. So average survival rate after the onset of full-blown AIDS is about the only just within a span of months. With children who are often have a rapidly progressive disease and full-blown AIDS occurring at age of 4 to 8 years of age. So this is a diagrammatic representation, that is how is a virus particle seen, the viral load is seen in the sample of a HIV case. So before HIV infection and after HIV infection, that is weeks to months and years together, and in the full-blown AIDS case where you have this completely loaded virion particles in the sample. So as per CDC, classification is based on the number of CD4 lymphocytes. So with the decrease in the CD4 lymphocytes, the patient will end up in complete full-blown AIDS. So if it is greater than 500 per ml, or if it is 200 to 400 per ml, or if it is less than 200 per ml, which is an AIDS indicator. So CD4 plus T cells percentage will be categorized as more than 29%, 14 to 28%, or more than 14%. Clinical category number A, category B, and category C. That is, category A patients will be asymptomatic or generally acute infectious cases, or else persistent generalized lymphadenopathy will be presented. Category B patients will be symptomatic, not like A or C, and condition like AIDS-related complex can be seen in this. Whereas category C, you have completely full-blown AIDS with indicators condition. Yes, so this B is nothing but the neurological disease, and C1 is an opportunistic infection. C2 is a secondary infection with candidiasis or herpes zoster and all those. And A3, B3, and C3 are together considered to have full-blown AIDS. So what are the major clinical manifestations which are being presented by this patient is wasting syndrome, persistent generalized lymphadenopathy, GI manifestations, pulmonary manifestations, mucocutaneous manifestations, hematological manifestations, CNS, gynecological, renal, hepatobiliary, cardiovascular, ophthalmic, musculoskeletal, and endocrine. So n number of systems are involved in our body by this HIV. So HIV infection of the nervous system plays a very important role where 75 to 90% of the cases, some form of neurological involvement is seen, especially in autopsy cases after the autopsy. So infects the microglial cells, astrocytes, and oligodendrocytes. So infection is carried to the microglial cells by the HIV infected CD4 plus T cells, monocyte macrophage subpopulation, or even by the endothelial cells. So direct infection of the astrocytes and oligodendrocytes also occur, and the only characteristic feature to be remembered over here is neurons are not invaded by the HIV. So this is a very classical thing which has to be remembered, but are affected due to attachment of GP120 and by the release of cytokines by the infected macrophages. HIV infected macrophages. What are the different neurological manifestations of neurological diseases the patient can present with? AIDS, dementia complex, meningoencephalitis, be it tuberculosis or cryptococcal, aseptic meningitis, peripheral neuropathy, demyelinating lesions of the spinal cord, and lymphoma of brain. What are the secondary opportunistic infections because of the degraded or completely destroyed immune system in our body? You get different fungal, viral, bacterial, and protozoal infections. So fungal infections contribute to candidiasis, cryptococcosis, then pneumocystis jirovecii, and coccidiomycosis, histoplasmosis nocardia. Histoplasmosis as well as nocardia. Viral is cytomegalovirus, herpes simplex virus 1 and 2, herpes zoster, EBV, that is Epstein-Barr virus, and human papilloma virus. Bacterial is mycobacterial infection or mycobacterial tuberculosis infection with mycobacterium avium intracellular and nocardiosis and salmonellosis. Protozoal and helminthic infections will be toxoplasmosis, giardiasis, amoebiasis, cryptosporidiosis, and strongylosis. Secondary neoplasms of the tumors which can be seen in an AIDS patient would be Kaposi's sarcoma, which could be multicentric or primary CNS lymphoma, non-Hodgkin's lymphoma, Hodgkin's lymphoma, and HPV-associated carcinomas like carcinoma cervix, carcinoma vagina, and anus, anal carcinoma. So therefore, different neoplasms which are because of this HIV infection could be in the early infection where you have the increased follicular T helper cells. And when the disease is progressing with the T cell depletion, those germinal center B cell hyperplasia occurs in the early infection. So AIDS-dependent DNA breaks and somatic hypermutation occurs over here, therefore leading to B cell lymphomas with translocations like Burkitt's as well as large B cell lymphomas. But when you have the disease progression to the advanced stage where your CD4 T cells are completely getting depleted, less than 200 per ml, then you have an unchecked EBV or Kaposi sarcoma herpes virus, then reactivation occurs in the latently infected B cells also, and you have these B cell lymphomas like Epstein-Barr virus, large cell lymphoma, then human herpes virus 8 plus primary effusion lymphomas, or Epstein-Barr virus along with Hodgkin's lymphoma associated lymphomas. So as a diagrammatic, just to remember the clinical manifestations of AIDS in different organ systems and also in the immunological system, what are the different criteria to call it as AIDS would be low white cell counts of CD4 less than 200 per cubic millimeter, opportunistic infections along with lymphadenopathy and fatigue. Whereas skin, that is integumentary, pure wound healing, skin lesions and night sweats, respiratory cough and disobey, GI tractus, diarrhea, weight loss and nausea, vomiting. Central nervous system symptoms will be confusion, dementia, headache, visual changes, personality changes, pain and seizures also. Opportunistic infections like protozoal, fungal, bacterial and viral. Protozoal is nothing but toxoplasmosis, cryptosporidiosis and all, and fungal infections like candidiasis, like stomatitis, esophagitis and vaginitis, whereas bacterial infections, mycobacterial infection, okay, tuberculosis and MAC complex, viral infections, cytomegalovirus, herpes simplex and varicella zoster virus, and malignancies could be NHL, that is non-Hodgkin's lymphoma, Kaposi sarcoma, Hodgkin's lymphoma, and invasive cervical carcinomas. AIDS dementia complex, where you have this cognitive, motor, and sensory disorders, where along with behavioral impairment in 70% cases. So how do you go for the laboratory diagnosis for this HIV AIDS case or AIDS case? So tests for establishing the HIV infection would be antibody tests by ELISA or Western blot, whereas direct detection of the HIV virus particles by P24 antigen capture assay, HIV RNA assay, nucleic acid PCR, and culture of HIV. And tests for defects in the immune system would be CD4 plus T cell count, which will completely get depleted less than 200 per cubic mm. CD8 plus T cell counts will be increased. Reversal of ratio of CD4 is to CD8. Lymphopenia, hypergammaglobulinemia, increased beta-2 microglobulin level, and platelet count will obviously show the thrombocytopenia in some cases. And tests for detection of opportunistic infections and secondary tumors will be either by FNEC or exfoliative cytology or by histopathological examination by biopsy. So this is a table which is showing the various serological markers of the virus proteins through different tests. That is ELISA, Western blot, P24 antigen capture assay, urine for HIV, HIV load, home screening, and oral mucosal sample. So ELISA is a screening test along with home screening and mucosal sample, oral mucosal sample, whereas the confirmatory test will be by Western blot, which is detecting the antibody to HIV, and P24 antigen assay also detects the HIV1 core protein. So therefore, it supports the Western blot as a confirmatory test. And marker for the diagnosis and AIDS will be by detection of HIV RNA, which is by the HIV load test. So tests for establishing the HIV infection would be antibody test and ELISA, which is the initial screening, and against GAG and envelope proteins. The term window period is very important in this lab diagnosis. It's used only when the initial 2 to 4 weeks period of time when the patient is infectious, but the screening test will be negative. And seroconversion is the term which is used for the appearance of the antibodies to that particular virus particles. So Western blot test, as I have told, is a confirmatory test after doing this ELISA, which is positive, and it will get the presence of specific antibodies against all the 3 HIV antigens called GAG, POL, and envelope proteins. So this is a picture showing us the Western blot test, which is depicted as positive for this GAG, envelope, as well as POL proteins. And direct detection of HIV is through P24 antigen capture assay, HIV RNA assay methods like by the reverse transcriptase PCR, then nucleic acid sequence based amplification, and DNA PCR by amplification of proviral DNA, and culture of the HIV from the blood monocytes and CD4 plus T cells. So this is a different picture which is showing us the different stages of this entry of the virus through the mucosal surface and then getting out, released into the circulation after getting multiplicated. And at each level, how are the different drugs acting upon it? Like you have this fusion inhibitors, CCR5 inhibitors, protease inhibitors, and you have this NRTIs as well as NNRTIs. So as a small questionnaire, which of the following is a rare and severe form of immunodeficiency where the individuals lack T and B cells will be? Yes, it's a severe combined immunodeficiency. The term itself tells about that. So not a primary immunodeficiency disorder would be, yes, AIDS. AIDS is a secondary disorder. Then what are the possible factors for the secondary immunodeficiency? So all of this above. And HIV infects the cells expressing CCR5. Thank you for the patience hearing.